Now,
sorry. Now, please, we've got three oral presentations by some of our trainees. The first one is Dr. Vijayan Nadella on anaesthetic management of porphyria to a rare congenital disorder, Langer mesomelic dysplasia. We've got 7 minutes for the presentation and 3 minutes for questions. Okay? Can I also let you know about the bingo cards? The ones that have been filled in, if you can please put it in a box near the stands. Okay? Thank you.
Hello everyone, my name is Vinayak. I'm one of the anaesthetic trainees at Calderdale Royal Hospital, Halifax. I'm going to tell you about one of the cases we did at the hospital. She was a lady with a rare congenital disorder called Langer's mesomelic dysplasia. So she's a 32-year-old primary gravida who presented to the obstetric clinic at around 12 weeks and was referred to the anaesthetic pre-assessment clinic around 15 weeks. As you can see, she had extremely short limbs and stature, but she had a normal torso. Her booking weight was 109 kilograms. Obviously, she put on weight further during the pregnancy. Her BMI was 57. In the pre-assessment clinic, when we assessed her, she had an earlier general anesthetic for some dental procedure. There were no notes available, but she said there were no problems with the general anesthetic. Her airway essentially was Malampati grade 2, and she had good neck movements. On examination of the back, the spinous process were just not palpable. So a little bit about Langer's mesomelic dysplasia. It's a rare disorder of bone growth in which there is extreme shortening of the long bones of the limbs, resulting in short stature. The torso is normal. Intellect and life expectancy is normal. It is caused by mutations of SHOX gene on the sex chromosomes. It is in something which is called as a pseudo-autosomal region, and it follows an autosomal recessive mode of inheritance. There is no case reports about Langer's mesomelic dysplasia in particular, but there are a lot of reports about related disorders of dwarfism, most commonly achondroplasia. So the challenges in her case were paucity of literature on this particular disorder and the mode of decision with regards to antenatal care, the mode of delivery, and the anesthetic concerns. So she was started on low-dose aspirin by the obstetricians. She had continuous fetal growth scans done for the fetal growth. Because there was less literature, there was positive literature about this disorder, we decided to do an echo because the related disorders like achondroplasia had cardiovascular implications. So the echo was normal. We did an MR of the lumbosacral spine, which was normal. To decide, to help with the decision of mode of delivery, we also did a MR pelvimetry, on which we found that her measurements were on the lower side of normal range, and she had a small pelvis. The obstetricians had a detailed discussion with the couple, and they offered the plan of going ahead with a vaginal examination and at term and deciding clinically how to deal with her. But the couple wished to avoid emergency cesarean section at any cost, and hence the plan was decided to go ahead with an elective LSCS. So with regards to management of our LSCS, as expected, the peripheral cannulation was extremely difficult, impossible. So we got a central venous access in the internal jugular. The spinal anesthetic was difficult, took multiple attempts, but was eventually successful. We couldn't find TED stockings to fit her, so it was decided to use floatrons to continue with floatrons till she was mobile. Otherwise, the spinal anesthetic went fine, and she delivered a healthy baby girl. and was discharged. The post-op recovery was uneventful and was discharged home on day 2. The learning in this case was, it was very important that she was referred to us early. She was referred to the obstetric clinic at 12 weeks. We have an antenatal anesthetic assessment clinic to which the obstetric colleagues referred her to us at around 15 weeks. So we got plenty of time to plan in advance, do the necessary investigations, and to come up with a elective controlled environment, which was the most important thing. We could do the MRI of the spine, echo, and plan everything. Because had she turned up in the middle of the night, even though she had a general anesthetic before, it would have been a very tricky situation. The other thing was, it's important because pregnancy is a thrombogenic condition, and because of her obesity, it was important to have a plan regarding the management of venous thromboembolism as well, because as simple as TED stockings, it was difficult for the TEDs to fit her. So essentially the take-home message is that if there is early referral and multidisciplinary management, it is possible to manage such cases even at a district general hospital. Thank you.
Any questions, please?
Any questions?
Can you tell us what dose of spinal you put in?
The consultant anesthetist was use a standard dose of 2.8 ml of bupivacaine with 400 micrograms of diamorphine. But he has a practice of sitting up the patient for a while, and it went fine. Actually, in Langer's mesomelic dysplasia, there is no spinal canal stenosis or anything. In achondroplasia, you have spinal canal stenosis where there could be an unpredictable high level of a spinal blockade. In this case, it was not so, and so the standard dose was used.
Thank you. Anybody else? There's one more question.
Hi, good afternoon. It's Faisal from Halifax. This case was done before I joined the trust. Just wondering, what was your backup plan if the spinal has failed?
She had a general anesthetic before, which she said that was without any problems. So,
Any features of airway difficulties or anything?
so she had a Malampatti grade to good neck movement, so probably a general anesthetic on her would have been straightforward, but yeah, general anesthetic would have been the plan.
Anyone else? Thank you very much.
Thank you very much.
May I now introduce Dr. Laura Pengelly for spinal anesthesia with high-flow nasal oxygen for C-sections in a patient with acute and chronic respiratory failure.
Hello everybody, I'm Laura. I'm one of the core trainees and currently work at Doncaster. I'd like to share a case with you today that involved the obstetric team, the critical care team and the anaesthetic team. So as we heard in one of the earlier talks today, intensive care admission, fortunately in pregnant ladies, is relatively rare. And the leading causes of that tend to be hypertensive diseases or blood loss, and actually acute respiratory failure is quite far down the list of reasons that people go to ICU when they're pregnant. However, obviously it is a very serious threat to both mother and baby in the rare cases that it does occur. There are multiple changes to the respiratory system during pregnancy, as we all know. One of the significant ones is that your FRC will actually reduce to about 80% of your normal value as you progress through the pregnancy. Now, that can impact on a normal, healthy woman, never mind a lady who already presents with chronic respiratory disease, which becomes significant in this case. There is a reasonable amount of literature now supporting the use of NIV in pregnant ladies and also during delivery and during caesarean section. Many of those are in women with pre-existing lung disease, a few of those are in acute respiratory failures. However, in the critical care setting, high-flow nasal cannula is becoming a very popular means of providing ventilatory support for acute respiratory failure, and there's really very little evidence of this in the obstetric setting. And actually, when I searched the literature, I couldn't find any instances reported for caesarean section. So the patient that I'd like to present today was a 30-year-old lady. She had a past medical history of significant spinal scoliosis. Difficult to exactly say how dramatic, because she's declined to have any imaging of her spine in adulthood. She also has a Klumpke's palsy, restricted lung disease, and a diaphragmatic hernia that was repaired in childhood. This lady had had one previous successful pregnancy in 2009. She had a baby girl that was born at 38 weeks by an elective caesarean section under spinal. However, a few days post-operatively, she did end up in intensive care with pneumonia, and she was treated at the time with inotropes and non-invasive ventilation, and she narrowly avoided being ventilated, fortunately, and she did go on to make a good recovery. However, she was advised, as you might expect at the time, that further pregnancy would not be a good idea, and she was cancelled to try and avoid further pregnancies. However, she chose not to follow that advice and presented again to the obstetric team a few years later. She was seen early in pregnancy by the anaesthetic team and also by the respiratory team, with hope of making another elective plan for delivery. When she was seen in an anaesthetic clinic, she was assessed for her disease state, which found she had an exercise tolerance of around about 100 yards, and she was then sent off for pulmonary function testing, which revealed that she had an FEV1 of 22% of her predicted value, and that was only done at 8 weeks of pregnancy, so really before any dramatic compression from the uterus is going to have occurred, which you can imagine was a little bit of a worrying statistic when we saw that on her pulmonary function report. So she then went on to present to a routine planned outpatient clinic appointment at 31 weeks gestation. But she was acutely dyspnea, tachypnea, fever, cough, and when they put SATs probe on her, she had SATs of 74% on room air, which I think somewhat upset the Obs-and-Gynae F2. So that was her blood gas done on admission. The ABG, when I first looked at it, I thought, oh, that's not too bad. But I suppose when you take into account what you would expect those values to be in a lady of 31 weeks gestation, it's perhaps worse than it initially looks. And she was then admitted to the antenatal ward, started on oxygen, started on antibiotics, and our initial diagnosis was that she had a lower respiratory tract infection on top of the compromise from her growing uterus. She was treated just with oxygen and antibiotics overnight. Unfortunately, she didn't make any significant change overnight. In fact, by the morning, she actually just looked more tired. She could barely move for breathlessness. Although her gases were actually relatively stable, they hadn't deteriorated, particularly in the night. But it was felt that because of how she looked clinically, we needed to escalate her respiratory support. So we decided that we would discuss her with the local tertiary care centre to see whether they would be willing to take over the care of this lady and manage her delivery and her critical care needs. Unfortunately, the local centre was not able to take her due to a lack of critical care beds. They don't have a designated obstetric critical care unit there, and their general critical care was full at the time. And their advice was that she could be managed locally and plan made for delivery. So that's what we did. She was admitted to intensive care for non-invasive ventilation. There then followed a very lengthy MDT discussion because unfortunately this was about 3 o'clock on a Friday afternoon, as these things often are, and the decision was made that we would wait over the weekend and deliver her on the Monday morning. Now the reasons behind that were for steroids to be given for the baby, for her to have 48 hours of respiratory support and of antibiotics in the hope that her condition would be more stable and confer her some benefit when she then went on to have a caesarean section on the Monday. Obviously there were arguments against that, which were that because of the effect of her growing uterus, maybe getting on with the section immediately would have been a bigger benefit. And there was a very long discussion between obstetrics and anaesthetics about that. And eventually we decided to deliver on the Monday. So then we had the options of a GA, part of her scoliosis, she had a fixed neck, well, that should be a very difficult airway. And she had previously had a successful spinal, so that was the option we went for. And it was suggested actually by the physio that we could take it off the BiPAP and use high flow nasal cannula. And the reasons for that were that it's generally much better tolerated by patients. You can talk to your patient while they're on it, it's humidified, it's much more comfortable, and we wanted to provide her with as close to a normal caesarean experience as we could. Her spinal anaesthetic was done by a consultant anaesthetist, very normal doses, normal position, went very smoothly. Congratulations to Dr. Kelly on that, I can't take the credit for that one. We continued the high flow nasal cannula throughout the delivery. She never dropped her sats below 94, we didn't have to increase the flows, and it was actually very successful. She had a live baby girl who was transferred to Skaboo, and mum was transferred back to ITU. So hopefully that is a useful thing to share, should you need to provide respiratory support.
6 minutes, 50
Just in the middle side. Any questions, anyone?
Yeah, just one question. What was the point in referring her to the tertiary centre? What would they do different?
Just the feeling was that this was a lady with very complex medical history, significant chest disease, requiring critical care input, and in general those patients from our district general would have gone to a tertiary centre, but they weren't able to take care.
Hi, can I just ask you what was the height of the block you had when you started the section on her?
So she had a block to T4, and actually she had to be positioned head down despite the fact she was under 5 foot to achieve that block.
Obviously you didn't have any problems with her being taking her off on BiPAP and putting her on high flow nasal oxygen.
No, she tolerated it really well. She went back onto the BiPAP purely as a sort of resting treatment at the end of the caesarean section once she got back to the unit, but she was fine.
Thank you.
Thank you very much. And last but not least, Dr. Slava Majdanovic on management dilemmas in high-risk pregnant women requiring respiratory support and intensive care management.
Just testing. Stop moving.
Sorry, I'm just testing. Doesn't work, sorry. Because I'm technical problems. I'm not very good with
That's resident, so that's quite good.
Okay. Yeah, I'm really sorry. I'm really sorry for these problems. I'm Slava, Dr. Majdanovic, one of the obstetrical trainees in Hull, and I would like to share our experience of dealing with obstetrical patients with a high risk. And they're all 3 unrelated clusters of case that we come across. We would like to share our experience of dealing management in terms of when to deliver, how to manage, what the course of their symptoms, and where to deliver. And I will touch about MDT involvement in this management of these such difficult cases, and we'll discuss briefly about evidence and way forward from it. I'm really grateful that you let me present these cases, and I am grateful for my team to help me to present these cases and choose these cases for us. The first lady is a 25-year-old lady who came to us 34 weeks pregnancy with vague symptoms of abdominal pain. She had a toothache. It was difficult to pinpoint what actually the etiology of her symptoms, and then she developed refractory myoclonic jerks. Obviously, all investigation is usual normal, which is one of the challenges in these situations. We have to go through a lot of the diagnosis, and we have to adjust our treatments one by one things to decide what actually can work with her. Initially we thought it could be because of preeclampsia, usually one of the surgical cases. We started on magnesium sulfate, things not improving. Thought about new onset of epilepsy, she was on clonazepam, doesn't help at all. Treated for infection for possible sepsis, which doesn't improve her symptoms at all. Because she deteriorated, the decision was to intubate her and transfer to intensive care unit. She seems to be improved with her jerks, but after extubation again, all symptoms recur. There was some suggestion of irritation of the uterus and some suspicion of CTG, and the plan was made after long discussion to proceed with cesarean section. The problem was for us where to do it, whether it's as previous candidates showed, previous people who did show us the map, but hospital we do have different setup for women's and children's and general ICU and tower block as main theatres. So there was a dilemma where to do these things and operations, but she had successfully cesarean section for suspected abortion and made very good recovery for this episode. The next case is a lady who is 33-year-old. As along with the cases we go, the prematurity crops a bit more. She was 26 weeks and 2 days. She came to us very unwell, with a shortness of breath, with a cough, lethargy. She required a lot of support from, she requires a lot of oxygen to maintain her stats, and things that were deteriorated. Initially we thought it was just a simple pneumonia, as you can see, although it didn't respond to IV antibiotics, or broad-spectrum antibiotics. We did not promptly, slightly later, we did the swaps and it confirmed she had a swine flu, although it was not suspected because we are out of swine flu, but it's a recent case and actually it's this January. That's why she has been started on tamoxifen. She initially was treated as CPAP in ICU. Unfortunately, things were getting worse. And after long discussion between anaesthetists, obstetrician and neonatologist, we decided that the option will be to improve her chances to survive and come out of this episode. It's cesarean section and then ventilation. She had cesarean section in tower block again, which is the main theatres. Made a reasonably long process of recovery, but everything was okay at the end. As you can see, the more things are coming through, the more cases are. Oh, sorry. So the more advanced cases you go, there is more prematurity. And the third case that we have a challenge is a 23-year-old lady, first pregnancy, who came again with cough for 4 weeks, abdominal pain. She had a history of asthma, and initially it thought it would have exacerbation of asthma, although it didn't respond for antibiotic treatment. And so the viral swabs came back, having a rhino or enterovirus. As far as we know, it's not common cause for causing any respiratory problems, but unfortunately she was deteriorating and needed ventilation and support. She has been on ventilation for 7 days, and clinically, not clinically, but generally she was making a pretty good progress. Because of prematurity at 23 weeks, we decided that to try to extubate and see what happened, because delivering the baby at 24 weeks is not a good idea. After extubation, she made a very good recovery. She continued the pregnancy with very strict obstetrical surveillance, and we induced her at 38 weeks. Unfortunately, she had a grade 1 cesarean section for IUGR and fetal distress in labour. So obviously, dilemmas and difficulties for us was
to decide where to deliver, how to deliver them. What first we do ventilation, we do treatment, whether deliver before, after, and as all anaesthetic colleagues just know, ventilation in pregnant women could be challenged, and we don't have much evidence to suggest what to do. Most of dilemmas in management depend on clinical experience of the doctors who are involved, because we don't have any guidelines as such. So as you can see, the Embrace report, the Embrace report suggested that when we have epidemia of swine flu, 1 in 11 patients were died, and most of the times because it was either delayed treatment, although it was suspected, it's not been started until we diagnosed. So the treatment has not been started quite late. And that's the outcome from Amber's report was that we're supposed to have the HDU care to provide a better care for our patients. In our hospitals, we don't have it, and the last year we admitted 12 patients to general ICU, and maybe having an HDU as a will be way forward in our unit. Obviously, MDT involvement highlighted that all decisions needs to be made after discussion with lots of teams to help us to make the right choice for our patients. And it just highlighted again that immunisation is very important, and we have to encourage the women from our point of view to have immunisation against influenza.
Sorry, I'm going to have to stop you there. Thank you very, very much.
Yeah.